Good afternoon, everyone. Most welcome to the Monivent webinar session number 2. My name is Maria Sipos, and I'm the Commercial Product Manager here at Monivent. Together with my colleague, Maria Lindqvist, the co-founder of Monivent, we will be your hosts today. We are honored to have Professor Georg Schmölzer and Dr. Nadya Yousef as our invited guests today. We have 1 hour scheduled for this webinar. We take the questions and answers in the end, so we will have 2 presentations and then followed by the questions and answers. So I will start with just checking, do we have a good sound? Is everything okay? If someone could just write in the chat, that would be great. Otherwise, I will start with a short introduction of Dr. Nadya Yousef, our first speakers, ladies first. Dr. Nadya Yousef is Senior Consultant, Neonatologist and Deputy Head of the NICU at Paris-Saclay University Hospitals in Paris, France. Dr. Yousef received her medical degree from the University of Oslo and has trained in Norway and in France. Dr. Yousef has a broad experience in neonatology and neonatal intensive care. Special interest areas include point-of-care ultrasound and the use of simulation-based training to improve patient safety and quality of care. Dr. Yousef is a pioneer in the field of neonatal lung ultrasound and has published extensively on the subject. She is co-author of the International ESPNIC point-of-care ultrasound guidelines. She directs a course on neonatal and pediatric lung ultrasound in Paris and has taught and lectured internationally in Europe, Africa, Asia, and North America. She's also a firm believer in the role of simulation-based training in improving team performance, patient safety, and patient outcomes. She's actively working to integrate simulation into the clinical reality in neonatal care through national and international collaborations in research and training. So the title of Dr. Nadya Yousef's presentation is Training in Neonatal Airway Management Towards a Multimodal Approach. So we will start with Nadya's presentation. So bear with me a second.
Hello, everyone. Thank you for joining us today for the second Monivent webinar. Thank you also to Monivent for making me part of this. My name is Nadya Yousef, and I'm a consultant neonatologist from Paris, France. I'm going to be talking about training in neonatal airway management and how we're moving towards a multimodal approach. I have no conflict of interest to disclose, but my team and I were so lucky as to evaluate some of Monivent's products in our units in the past. I've also been very lucky to be able to collaborate with Emergency and Improve Academy, who both try to improve quality of care and patient safety through simulation-based training. In neonatal care, airway management is really a critical component. We'll all be faced with trying to manage neonatal airways, be it as an emergency situation in the delivery room, or maybe more as a programmed or semi-programmed care for babies in the neonatal intensive care unit. We know that adequate neonatal airway management requires a high level of technical skills. We're faced with unique challenges in the neonatal period because of the newborn's specific anatomy and physiology and reactions to our airway management techniques. We are also faced with the knowledge that ineffective airway management may lead to adverse events and potential long-term negative outcomes. We have challenges in training. Ideally, we should all be prepared at all times either as individuals or as teams, to lead with, to be prepared for an airway management situation. But in practice, we have a number of challenges when it comes to training. First of all, for our trainees, there is reduced exposure. Most of that is also because we're gradually shifting towards a less invasive approach to our babies with more non-invasive ventilation. So the opportunities, for example, to intubate are less. And in many countries, there have been restrictions on duty hours for trainees, which also increases that problem. The equipment we have, if we're using simulation, is that we have a number of limitations, be it in the mannequins or the way we're using them. And up till now, many of us are mainly focusing on technical skills. However, we don't really know how that would translate in the clinical environments. And another question we could ask is, once we've actually acquired the skills, how do we maintain them? All skills we learn are subject to decay, and we would need refreshers ideally. Simulation-based training is emerging as the leading educational modality for neonatal airway training, and it comes as a supplement to clinical practice. We've been using it to teach initial skills, but also to maintain competency and for teams training, which is gradually really getting a bigger place in our training, because we know that when in clinical practice, we're actually managing neonatal airways. It is not just the technical individual skill. We're actually working as a team, and therefore we need to be addressing more than just the technical skills. We need to be talking about non-technical factors like teamwork, for example, communication, environmental design, and think about how we function under stress. What's very good about this is that we can program the timing for training, adjusted to learner needs and to the team needs and to specific needs in the unit, for example. It could be as procedural simulation training sessions, like standalone sessions, or could also use them like just-in-time training, meaning that somebody that has been trained could be retrained just before, for example, going to the delivery room where we're expecting the need for airway management. It has been used as part of a curriculum for boot camps or in neonatal resuscitation programs. And in many units, like in mine, we have included it in the clinical quality improvement programs. We could also be using in situ simulation, which is really just recreating the actual clinical scenario in our own unit or in our own setting using our equipment and our teams, where we recreate the stress of difficult airway situations, for example, to train teams to respond to that. So there are many, many ways of doing this, and they don't necessarily need to cost that much. Most of what has been studied in simulation research is neonatal endotracheal intubation. It's a challenging procedure. And unfortunately, we still have low first-pass success rates. It requires a high level of technical skill that needs to be maintained. And I think we must all admit that most of us are in settings where we often may need to have multiple attempts at intubating, even though the airways may be normal, because of the newborn's specific physiology. There's a low tolerance to hypoxia with resulting bradycardia. And we know that this may also lead to potential additional complications. The impact of simulation-based training on skills levels has been evaluated in the simulation setting, but translation into clinical practice still remains a bit difficult. We are lucky to have significant improvements in our training equipment. Today, we've got specific task trainers. We also have high quality mannequins that are full body models, where there are features that we can, have procedural practice of intubation. Some even have internal sensors that can detect tube placements and lung inflation and so forth. And now we're moving towards more virtual reality and augmented reality trainers that could incorporate advanced assessment tools to track the laryngoscope and head motion and so forth. But I think we all agree that there is a potential benefit to self-directed learning as compared to, strict instructor-based learning, especially for maintenance of skills and for more experienced providers who often, will have a certain level of competency, but will need to keep this being renewed. Many centers and many trainers will use a video laryngoscopy as a tool for neonatal intubation training. When it comes to the simulation-based training we have today, we have kind of mixed results comparing the success rates using video laryngoscopy as compared to direct laryngoscopy. But that may also be because we've got various definitions of what success means, what kind of equipment we're using, and how much actually the learners are allowed to use it. Video laryngoscopes magnify the airways and allow good visualization, which is really important when you're learning how to intubate. This in the beginning. They have the benefits also of showing learners how the laryngoscope motion facilitates the visualization of the anatomic landmarks. And this is probably why the benefits is greater for novice learners. These skills are frequently transferred to direct laryngoscopy during simulation-based training. And that shows how important it is to learn effective visualization of the airway anatomy. For more experienced learners who have already learned how to intubate with a different method, it might be a bit more tricky. Video laryngoscopy has a steeper learning curve in clinical practice. And in the clinical environment, it does improve first attempt success, which is great. The decrease in number of attempts is really something beneficial because we know that multiple attempts can create edema and may create other problems. However, it does not seem that VL actually decreases the overall time to intubation or the number of adverse events. What has been shown to be beneficial is using video laryngoscopy with real-time feedback and coaching, and that does improve intubation outcomes. When it comes to the safety, there are a number of things we can modify. We know that success of intubation is clearly influenced by the level of experience of the clinician and by the use of video laryngoscope as compared to direct laryngoscopy. And in addition, preparing the infant by use of muscle relaxants and adequate sedation. Other factors are not factors we can modify, like, for example, the weight, the reason why we're intubating, hemodynamic instability, for example. All these factors increase the potential for adverse events. And thus, it's very important to have clear intubation safety strategies. As a unit, as a team, we need to select clinical management strategies that improve the likelihood of success. And in my belief, it is especially important to have clear guidelines and algorithms, especially for difficult airways, because when we're faced with that, we're quite stressed. It's not the time when we need to start to think we need to be able to follow steps that have been pre-designed in order to improve the probability for success. We, however, do also need new equipment to aid us clinicians. And we need to have an environment that is optimal, be it the lighting, the equipment, everything else. And we need to be able to have an accelerated skill acquisition for different procedures. Well, what we do first, the first step we have when we're faced with, let's say, an infant in the delivery room with having problem transitioning. Well, the first steps in the current neonatal resuscitation algorithms are to start positive pressure ventilation with a face mask, bag and mask, or ideally with a T-piece. However, it is challenging also. Achieving effective ventilation with minimal mask leak or airway obstruction at a consistent rate is challenging. It is not easy. And we train a lot of mannequins, and we train a lot in simulation-based settings, but it's difficult to transfer to live patients. And one of the reasons is that we have difficult mechanical properties in the mannequins we're using as compared to the lungs of newborn babies, preterm or term babies. In addition, unfortunately, like all skills, they are subject to decay, and we need to regularly retrain. I find that one useful tool to be able to use in training in bag mask or face mask installation is the use of respiratory function monitors. They have been around for some time. They offer direct visual access so that learners are able to self-adjust. And by using this, learners are able to keep the tidal volumes or keep the ventilation parameters within what is recommended. Because as we know, not achieving adequate ventilation is dangerous, but also overventilating may be potentially dangerous also in the long run. So we need to be able to keep a consistent, adequate ventilation over time until either we stop ventilation or we move on to the next step in the algorithm. Factors such as where we place the monitor are important because we know that visual access and the way we're using your eyes during your neonatal resuscitation setting is important. The experience of the providers is really important. And of course, the type of the device we're using can impact the quality of the ventilation. A recent study that came out, I think this year, shows that giving direct visual access to respiratory function monitor, both the supervisors during training and the learners, improves the quality of bag mouth ventilation versus access only to supervisors or no access at all. But what about the effects of previous clinical experience? Does it really change? Is it an advantage only for novice learners? We could argue that for more experienced providers who's already learned how to use other cues, tactile cues, how the chest is riding, how the baby is responding, might find learning something new, like adding, for example, a respiratory function monitor be an additional cognitive load. And what about the transferability to the real environment? Today, we have insufficient evidence from clinical trials to support the use of respiratory function monitors during neonatal resuscitation. But who knows? Maybe in the future, we'll learn more about this. And what about retention of skills? Is this improved quality of face mask ventilation observed when we're using respiratory function monitors something that will persist? Or do we always have to have real-time access to that? This is also a question we don't know. We definitely do know that we need to investigate the use of RFMs further in terms of gains stratified by experience level and to evaluate retention of knowledge and skills over time. Difficult airways are frequent in the neonatal period. Actually, they're much higher than later in life. And the rate of difficult neonatal intubations is high. It's been defined as the need for more than 2 attempts. They're they're difficult to anticipate because they usually occur with anatomically normal airways, which is why it is extremely important for teams to have planned in advance and anticipated to be able to respond adequately in case of an unexpected difficult neonatal airway situation. We know that from anesthesia, where they have pre-planned algorithms and where everything has already been prepared for the worst case scenario, which means also that when it comes to training, we need to train our teams in the technical and in the non-technical skills needed for an unexpected difficult airway situation. And although it's really frequent in neonatology, not many institutions have their own difficult airway algorithm. And we have to go back to the basics. Our main objective in airway management is to maintain ventilation oxygenation. It's not, for example, to get an endotracheal tube in, or it's not, for example, to follow a specific algorithm. Our main objective is to maintain ventilation oxygenation. And we need to be able to do that even when it's difficult, which means that it's much easier to be able to respond adequately when we have predefined steps, how we should escalate rapidly and in an adapted fashion in the case we're faced with difficulty. Difficult airway algorithms, in my opinion, are necessary, like, for example, the British Association of Perinatal Medicine. And it's important to be able to distinguish between a situation where we cannot intubate, where we can ventilate, because we can use alternative airways, or we can continue face mask ventilating until we get help or until we manage to stabilize the patient. This is completely different from a situation where we cannot intubate and we cannot ventilate, which defines a failed airway, and where we really, really need to move quickly on to rescue technique. This is real emergency. And in an emergency situation like this, in addition to have clear predefined steps. We also need to be able to function with clear communication techniques in order to give optimal care to our patients. One of the alternatives we may have, and that these are the supraglottic airway devices, where we ventilate without going through the vocal cords. They've been incorporated into our current guidelines for neonatal resuscitation. They may act as a bridge between a face mask ventilation and intubation, but they can also be used as a first-line airway management device, as they are easy to insert blindly. We know they're easy to learn how to insert with a high success rate, and the degree of skill retention is high. However, not many of us are really trained in that. They could be very useful in a difficult or impossible intubation situation where we need to ensure oxygenation, especially where if we're not able to do so using face mask ventilation. Ideally, in any situation or in any setting where we're faced with intubation, we should have supraglottic devices available. And now we're able to use these in infants, near-term and term infants, as low down as 1.8 kilograms. And I know we're working on getting them down. I think it should be quite soon before we have them also for smaller infants, which until now has been a limitation. So going back to the situation, the clinical situation. Most often when we're in an airway management situation, especially difficult airway management situation, we're very stressed. And we know how stress and heightened emotions can actually compromise the quality of care. For example, if we have a very unstable patient, such as hemodynamic instability, or an infant that is not responding to usual resuscitation measures, and we don't understand why, which is where the importance of what we call human factors come in, how we're working together. Coordination, leadership, communication. So everything is actually happening to the best of our ability in order to give the best quality of care possible. Ideally, simulation-based training should prepare the teams for the stress of the clinical situation, either through realistic scenarios or through stress training. Some units like ours, for example, we go through cross-training, which means that, for example, our nurses will be trained in some procedures like, for example, intubation, which they usually don't do in our setting, in order to understand what the physicians go through when they're trying to intubate sick babies. And the physicians will try and learn, for example, the nurse perspective, certain skills, which allows us to have shared mental models and anticipate and understand what the other needs. And this is highly useful in high stress situations. So my conclusion would be that we have a long way to go. There is still, we don't know what the optimal training model is, but it's clear that no universal training method would fit all. We have different settings where we're working, we've got different levels of experience, and we learn differently. So probably I think that a multimodal method would be necessary to cover all the aspects we need for technical, non-technical, individual, teams training, and the different settings where we're working in. Probably training modalities with self-directed and learner-centered components with a scaffolded approach would work well. We're adult learners, and we learn in a different way than initial novices or children. We definitely need more focus on non-technical skills and teams training, because that's usually where things go wrong. And hopefully in the future, we will be able to get more research on how emotions and stress affect our performance, be able to integrate that into our training. We definitely need technological advances in our airway simulator design to be able to not only have the same airways, but be able to modify that to have mechanical properties that are close to our patient's properties. But what I would really advocate for is integrating clinical quality improvement data, outcomes, adverse events into our simulation-based training in order to improve patient care. We still have lots of questions about how we can translate the results from simulation studies to the clinical environments. And I think that must be a priority, because in the end, what we're looking for is improved patient care and improved patient safety. So we need more studies. We also need to benchmark so that we don't have variability in training outcomes. We need to know how we can learn efficiently, learn well, and how we can retain skills so that together as a team, we can give optimal patient care at any time, be it at 3 a.m. in the delivery room or through planned care. I'd like to thank you all for listening to me. And I'd like to thank my team, with whom it's always been a pleasure to work. You can see all of them in this tree that we have on the wall. And if you have any questions, please don't hesitate to send me an email. And then, of course, there's a Q&A session. Thank you very much.
Thank you, Nadya. Let's see. We will take the questions in the end then. And I would like to present our next speaker, which is Professor Georg Schmölzer. Professor Schmölzer is a clinician scientist with a focus on fetal to neonatal physiology and neonatal cardiopulmonary resuscitation. He is the director of CESAR, Center for the Studies of Asphyxia and Resuscitation at the University of Alberta, and a neonatologist within the Northern Albertan Neonatal Program, providing care to critically ill newborns. He's also Professor of Pediatrics at the University of Alberta. Dr. Schmölzer obtained his MD at the Medical University Graz in Austria and trained in pediatrics and neonatology at the Medical University Graz and the Royal Women's Hospital in Melbourne, Australia. He obtained his PhD at Monash University, Melbourne, Australia, before completing a 2-year postdoctoral fellowship as a Banting postdoctoral fellow at the University of Alberta. Dr. Schmölzer's research focuses on understanding physiological changes during fetal to neonatal transition, improve diagnosis, mitigate risk, and improve survival and quality of life for newborns, use of emergency technologies during neonatal resuscitation, and examine how these physiological changes can be used to improve short and long-term outcomes of newborn babies. Dr. Schmölzer has participated on numerous peer review committees and scientific advisory boards at international, national, and provincial level, including Canadian Institutes of Health Research, Heart and Stroke Foundation Canada, and the International Liaison Committee on Resuscitation. His research is funded by the Canadian Institutes of Health Research and the Heart and Stroke Foundation of Canada. So we are pleased to have Professor Schmölzer presenting here today. He will be talking about chest compression techniques in the delivery room. And let's see, Professor Schmölzer.
Hello, my name is Georg Schmölzer. I'm a professor at the University of Alberta, and I'm excited to be here today with my esteemed colleague, Dr. Yousef, and I would like to thank Monivent for organizing this webinar. My talk will cover chest compression techniques in the delivery room, and I would like to disclose the following. I also will present some results from a currently unpublished trial. The majority of newborn infants make the transition from fetal to neonatal life successfully, without our help. However, 10 to 20% of newborns need respiratory support, which is the most critical step of neonatal resuscitation. The need for chest compression in a delivery room is rare. However, when chest compressions are delivered, it is associated with high incidence of mortality, as well as short-term neurological morbidities, as well as long-term neurological sequelae, including long-term neurodevelopmental disabilities. The poor prognosis associated with receiving chest compression in a delivery room raises the questions as if there are improved chest compression techniques or approaches which are specifically tailored to the newborn that could improve outcomes. The inability to predict which newborn need CPR, and because we're using it so infrequently, has certainly limited our ability to perform rigorous clinical studies on this subject. The current consensus of science and treatment recommendation statement say that you should start chest compression if the heart rate remains less than 60 per minute despite adequate ventilation. Use a 3-to-1 chest compression to ventilation ratio with 90 compressions and 30 inflations. Use a 2-thumb encircling hand technique over the 2-finger technique. Use a depth of 1/3 of the anterior to posterior diameter and use 100% oxygen. For the next 20 minutes or so, I will cover all of these statements with a main focus on the 3-to-1 compression to ventilation ratio. Now, to actually identify what heart rate level we should use to start chest compression, unfortunately, I can only say that there is no clinical study who has actually examined this in humans. There's also no animal study who has examined different heart rate threshold with longer term outcomes to see if there is an advantage or a disadvantage of starting chest compression or not starting chest compression. There's limited evidence from animal studies that if you have a rhythm and start providing chest compression, it interferes with the cardiac output and changes the blood flow situation within the heart and the blood going or coming from the heart, but otherwise the evidence is rather limited. What is the optimal rate? Well, there is a mathematical model who suggests that the optimal rate depends on the weight and the size of the patient. So in this model, it's stated that a rate of 180 chest compressions per minute might be optimal in a 3-kilo newborn infant. So in our lab, we have used a self-designed chest compression machine, which can provide chest compression to our animal model, and we examined that in more detail. What we found is that yes, the cardiac output, which is nothing else than the sum of stroke volume and rate, is the highest is 180, but it appears that the stroke volume, as well as the end diastolic volume, as well as the left ventricular function, might be optimal at a rate of 150. Now, while we have not examined the rate of 150, we have examined the rate of 180, the rate of 60, as well as 100, 110, and 120. And what we found is that there is actually, in all of these studies, not really a difference in time to return of spontaneous circulation or time to ROSC. Yes, as you can see in this study where we compared 180 to 90, the time with 180 of time of chest compression was much slower, but it was not significantly different. However, it seems maybe higher rate has the potential to improve outcomes. Second thing in the guidelines is the depth of 1/3 or 33% AP diameter, which results in higher ejection fraction, which is based on an MRI and a CT scan of children and newborns, suggesting that this might be the optimal one. Again, in our lab with our chest compression machine, we try to examine this, and what we found is that if you use a chest compression depth of 12.5% of your anterior posterior diameter, you will not get any cardiac output, and none of those picklets achieved ROSC. If you used 25, 33, or 40% depth, all of them received return of spontaneous circulation. Yes, the more depth you have, the higher your cardiac output or your carotid blood flow is. It changes slightly your systolic blood pressure, but it did not affect your diastolic blood pressure. So it might be better to focus on pushing to a threshold or pushing hard, because we have no feedback devices, but the 33% might not be the optimal. It might be in a range between 25 and 40%. Finger and hand position, as you can see from this recent scoping review from Ramachandran, that there is many different positions who have been studied in mannequin, but not in either piglets or in humans. And in one of the studies we compared 4 different finger positions and found that the two thumbs as well as the over the head two thumbs technique were favorable compared to the other two for some of the left ventricular function as well as stroke volume. So we concluded that the two thumb or over the head two thumb technique should be used compared to the other two we examined. For oxygen, there is a total of 7 studies in piglets available. However, none in human and not even an observational study who described if 100% or less oxygen were used. In a meta-analysis of the same studies who provided mortality or time to ROSC, there is no difference in either of them in the piglet model, but the longest survivor was up to 4 hours and none has done a neurological assessment. So that certainly is something where we do not know if 21% might be as good as 100%. In trying to perform a clinical trial comparing 21 with 100% oxygen during chest compression, asking colleagues in neonatology, the majority, and there's like 95% of them I asked, would be happy to compare 50 with 100%, but not 21 with 100% doing chest compression. It certainly then limits the ability for yourself to try to organize a trial if there is certainly not enough equipoise to try both of them. The last thing, and this will be now the remaining 10 to 12 minutes of my talk, will be focusing on the 3-to-1 compression to ventilation ratio. Now, it is stated that we use the 3-to-1 compression to ventilation ratio because there's a higher physiological heart rate, so we need to provide more chest compression, but also with a higher breathing rate, so we need more ventilations to get oxygen in, because bradycardia or cardiac arrest is caused by hypoxia and hypercarbia, which is our main cause of cardiac arrest. So if you provide ventilation, that's more beneficial. However, what we don't know is what's the best approach. What's the optimal compression to ventilation ratio? Now, to understand what we need, I think we need to go a few steps back and think about things we might not think at all. Now, if you provide chest compression, there is 2 theories why the blood is flowing. The cardiac pump theory states that because you push the sternum down and you push the heart against the spine, you squeeze the heart like a sponge and blood is expelled. When you're doing chest recoil, blood flows back into the heart. Now, the other theory is because you do chest compression. With chest compression, you get an increase in your interthoracic pressure. And because the interthoracic pressure increases, the blood is flowing. Now, these are the 2 most common theories of how the blood is flowing. And I think whatever we do, we need to use both of them. But what is often overlooked is a negative effect of chest compression. Now, this is a beautiful study by anesthesiology colleagues from Edmonton, where that went into the theater and had almost newborns all the way up to 18 years old, and pushed gentle on the chest to just see how much gas is moving in and out of the chest by pushing onto the chest. Now, the bottom graph is the one I would like you to focus. You can see the dark black line, which is the dead space estimated by 2 milliliters per kilo for each patient. And if you zoom in into the initial year of 0 to 1 year of age, you can see that there are several of these patients where they gently push the chest, and you can see that the volume moved and expelled is over 4 mils per kilo. And that certainly is concerning, because if you only gently push on the chest, you already get that much volume moved. Similar, when we looked at our patients, we used a force of 2 kilos, which is much more than what they were using in this experiment. And you can see at the bottom that between 25% chest compression depth and 40% chest compression depth, the volume moving changes quite dramatically. Now, this is something I would like to focus in the next few slides even more. Now, this is 3 to 1, which you all know, where you give a inflation and then you get 1 and 2 and 3 chest compression, inflation, 1 and 2 and 3 chest compressions, and then again. So this is classic approach. And now when you analyze the gas flow pattern and how much tidal volume is moved in and out, you can see that the inflation provides a large tidal volume, but then you squeeze the chest, a lot comes out because of your compression. During recoil, if you use 3 to 1 with a PEEP of 5 or 6, a little bit of volume comes back in, and then more comes out with the next compression, and then a little bit comes out, and a little bit goes back in, and a little bit more comes out. And overall, with each of these cycles, there was a difference of 4.5 mils per kilo, which could be lost. So now, if you would provide chest compression over a longer period of time, there could be quite some loss in tidal volume over time. That certainly is concerning, and might be a reason why, when several different studies tried to compare different compression to ventilation ratio, they did not find any difference. An alternative which is often brought up is continuous chest compression with asynchronized ventilation. Now, this is a video which you might often see in an emergency room or in a pediatric intensive care unit, where again you provide a ventilation and then you do chest compressions, and these chest compressions are continuous, and after every 6 or 7 chest compressions you will provide another inflation. Again, similar than the one before, you get a good volume in, but then with each chest compression there's more volume losing than you recruit. So again, you get a loss of tidal volume over time, and that might be a reason why your duration of chest compression could be longer. When you compare this to a technique we used and designed in our laboratory, where we combine chest compression, which is given continuously, and provide a high distending pressure, which we called sustained inflation, in short CCSI. With this technique, we, as you can see, were able to improve survival and significantly decrease the time to return of spontaneous circulation. Now, what's the difference? Again, if you look here, you just provide a sustained inflation by occluding the T-piece and provide continuous chest compression. The duration of the sustained inflation is 20 seconds. Then you lift your finger off for 1 second and you put it back on again. And with this, you can see that gas is moving continuously in and out with each chest compression of the lung, thereby basically passively ventilating. And if you analyze it in this cycle of all of this chest compression, you have a gain of 2.3 mils per kilo. So you don't lose volumes, you don't de-recruit the lung, you're actually recruiting the lung to continuously provide open lung and preferable optimal oxygenation. The second part is, and that's another reason for our technique, is that with the continuous chest compression as well as using high descending pressures, we use two techniques to increase endothoracic pressure. And in animal studies, when they're compared 3:1 with CCAV, so this continuous with asynchronous ventilation, you can see that there's no difference in hemodynamic parameters. However, when you then compare that to CCSI, you can see that 3:1 and CCAV were basically both the same, but CCSI is significantly improving your carotid blood flow as well as your pulmonary artery flow. Your pulmonary artery and mean arterial pressures are also higher, but your CVP, because of the fear of impaired venous return, is not an issue. So over a decade or so, we have done many studies and found in all of our studies that it provides faster time to ROSC, lower mortality, it improves your hemodynamic, it improves your minute ventilation and your oxygenation, you achieve passive ventilation, and you have no pneumothoraxes or any problems with lung or brain injury. So, randomized controlled trials in the delirium might be warranted. We did the pilot trial in less than 32 weeks gestation, only recruited 5 in the CCSI group and 4 in the 3:1 group. And as you can see here, there was a significant improvement in the time to ROSC, similar than what we saw in the animal model. Yes, there were 2 deaths in the CCSI group, but some of these kids were as small as 24 or 25 weeks gestation. Minute ventilation was significantly improved, and this might be the reason why the time to ROSC was significantly faster. So this then all resulted in the SURVIVE trial, which was completed last year, which was a multi-center trial comparing our technique with 3:1. The steering committee and the data safety monitoring committee you can see here. The primary hypothesis was that in asphyxiated newborns, CCSI compared to 3:1 will decrease the time to ROSC. We looked at our data and found that we would need a sample size of 218 infants, because it's a cluster trial with 119 infants in each group, and we would include all newborn infants requiring chest compression in the delivery room and exclude according to these exclusion criteria. It was a cluster randomization to one of the 2 groups, and each hospital would be with this group for a duration of 12 months, then a 2 months washout period, and then do the other 12 months with the other group. 3:1 was just your standard 3:1 approach. CCSI, as I described earlier in the video, continuous chest compression at 90, you do your SI for 20 seconds, a second pause, and then another one, pause, another one, pause, was 1 minute, heart rate assessment. If after 5 minutes with CCSI chest compressions are still ongoing, you need to convert to 3:1. These are some of the outcomes we were looking into for this trial, and then as you can see, none represents a particular city. They all represent sites who were interested to participate. Unfortunately, the SAIL trial was published as we were starting the study, and as the SAIL trial showed that sustained inflation as an initial respiratory intervention, not doing chest compression, has a higher mortality in infants born between 23 and 26 weeks gestation there certainly was some concerns for our intervention. So the trial was stopped, discussed between the steering committee and the DSMB, and infants only over 28+0 and term requiring chest compression delirium were now included. As you can see, this led to certainly a drop out of many sites because they were worried about the intervention. So we stopped the trial, restarted in Edmonton. We struggled with ethics boards who did not want to approve the trial and waited for more data. We struggled with contract negotiations because insurance companies didn't want to take the risk on to examine newborns receiving chest compression. We got finally under the way, had 6 sites basically ready, but then COVID came around. We had to pause the trial again. And in the end, we got to 4 sites who were able to participate in the trial. After 5 years of trying to get the study done, we stopped the trial. And as you can see, there were 11 in the CCSI group and 14 in the 3-to-1 group recruited at that time. There were no difference in the demographics, no difference in the delivery room intervention. And the primary outcome, as you can see, was time to ROSC, which was 615 seconds on median with the 3-to-1 and only 90 seconds with CCSI. Because the numbers are so small, it was certainly not significantly different. But as you can see in this database analysis, you can see the time roughly for 3-to-1 is somewhere between 6 to 8 minutes. So with our 10 minutes, 6 to 9 minutes. So with our 10 minutes, we're roughly in between this time frame or this duration. Survival was 82 with CCSI and 42 with 3-to-1. And depending on the database you look at, it's around 60 to 70% potentially in database. There was also no difference in secondary outcome. Mortality as well as pneumothorax and intraventricular hemorrhage were safety outcomes. And there were also no difference compared to using 3-to-1. Where does that leave us now? Well, there is 2 studies now done by us, and in both we have an improvement in time to ROSC, on average up to 2 minutes, given the numbers we have. So this now leads us that we want to do now a larger trial and hopefully get more patients and many more sites. So if there's any interest, please contact me on the email up on the screen. And I would like now to thank all of my members of the team and everyone over the years who involved with working on CCSI. And if you're interested, please email or follow us on Twitter or YouTube. And I'm happy to answer any questions.
Thank you, Professor Schmölzer, and thank you, Dr. Yousef, for your presentations. So we now open the floor for, or the chat for questions. We have received a few questions already. Maria, if you would like to take the first one.
Yeah, so the first one is for Dr. Yousef. So how can we evaluate if okay. In the meantime, we'll take a question for Professor Schmölzer instead.
Yep.
And see if we get the audio going.
Yep.
So we had a question about RFMs here. So what's your experience of using RFMs during chest compressions, and how can this feedback best be utilized in the setting?
Can you hear me?
Yep.
Yeah. I think, I think if you routinely use an RFM, you can certainly use it during chest compression as well. But I think once you do like 3-to-1, I think the big focus will be on trying to get the algorithm right, trying to get this coordination between mask ventilation and chest compression correctly. So I think the focus will certainly change and to trying to get this right. I think the RFM can certainly help you and has great values. First of all, to see that you can get a breathing tube in, that the tube is in the right spot, that you're ventilating, because it happens that the tube falls out during chest compression, certainly because it's not always secured. If you use a laryngeal mask, which might be done in some sites, then you can also see how the gas goes in and out. So that's certainly just for using function monitoring during chest compression, because it can help you to see what you do. Now, some of the things I talked about, that you see that you lose more volume, I mean, you can monitor that, but with 3-to-1, there's nothing you can do to improve it, because you can't really squeeze the chest, like squeeze the T-piece harder, like because even if you go up on the pressure, you get more volume in, but because you squeeze, the volume comes out again. So I don't think it's a way yet at the moment to figure out what to do to keep the lung open, but you can certainly monitor your volume.
All right, thank you.
So
Are you back, Nadya?
can you hear us, Nadya? Yeah, and can we hear you is the question.
So the another question, follow-up question for you then, Professor Schmölzer. If the recommendations on tidal volumes that are during manual ventilation in general, should they same be applied during 3-to-1, the 3-to-1 approach?
Yes, I don't think you should change the volume you're giving doing 3-to-1. Like if you use a piece, I'm not 100% familiar with the approaches in Europe for mask ventilation, but in North America, where you do Mr. Soap, or let's say you start at a peak inflating pressure of 25, then you go up. So then you certainly get more volume in when you increase. So I think you can adjust your pressures that you can get to that 4 to 8 mils per kilo. Yeah. Doing chest compression. So I think you might have to adjust your pressures to get there. So that would be the way of targeting that volume. Would I go higher? No, because particularly when it might not be a big issue with the 8 mils in a term infant, yeah, because the lungs might be, more mature to withstand 8 mils per kilo, but it hasn't been studied, not even in an animal model. But if you go in a preterm baby, I would be worried not only about the lungs, but also about the brain, because there's more and more research coming out that high tidal volume initiates a cascade in the lung and then affects the brain. So certainly wouldn't go higher than 8 mils in a preterm baby if we would, particularly in the lower end of the prematurity, if we go less than 29 weeks, where brain injury might be higher and more common than in a 32-weeker.
Thank you.
Okay. Then you asked a question to Nadya. I don't know if can you?
Third time is a charm. Can you hear me now?
Yes, loud and clear.
Brilliant. Oh, perfect. I think the question was about if we have any evaluation methods for our airway training. And I think it's a good question, because I think we don't have perfect evaluation methods. I mean, there are numerous evaluation methods that have been developed to monitor skill progression and competency acquisition, but it each has its advantages and disadvantages. So individual skill development can be used using, for example, personalized evaluative measures such as CUSUM, cumulative sum analysis. It's a statistical method by which individual intubations are tracked cumulatively over time for each learner. Each successful intubation brings the trainee closer to the predefined competency thresholds. But we also have a qualitative assessments, for example, with checklists, global rating scales, and also more trustable professional activities assessments. But I mean, I think we still have to work on getting assessment tools that can address milestones of competency and proficiency. For example, the ability to detect and respond to technical variations, the ability to handle cognitive load, tune out distractions, and so on. So I think there's a long way to go. So I'm not really sure. I hope I answered the question and that you could hear me.
Thank you. I think we have one from, let's see, I have my contact lenses in. Thanks for great presentation, Dr. Schmölzer. I wonder what you think about synchronized versus unsynchronized CC ventilations depending on airway adjunct. By now, should we do it all unsynchronized, even if we do intermittent ventilations?
Yeah, I was just about to answer that question because I started to answer one of them. I think it's a really interesting topic because if you read the latest guidelines, there will be laryngeal mask much more prominent. So I think by 2025, the textbooks might update that you can do a laryngeal mask or an endotracheal tube. I think that will be an individual decision. Certainly in North America, I can't see that someone will do continuous chest compression because it's not part of the NRP guideline, and it would be you're way too open to medical legal issues, just in case it gets wrong. If it goes right, no one cares. But if it goes wrong, so I think there will be a lot of people who would step back and say, "Now we're going to continuous feature one." But yes, continuous might be a way to go. There have been studies to do continuous versus 3-1, and they didn't really find much different. Like there's a couple of studies, one in the piglet model, one in the sheep model, and they compared the pulse approach versus 3-1, and it was the same. So there wasn't really any improvement. So yes, you can do it, but it might not improve your outcomes if you try it. But I would always be cautious and see what the guideline says, because if something goes wrong, you might be really open for medical legal issues afterwards.
Thank you. Yep. Let's see. We had one earlier as well for Nadya. I don't know. Let's see if we have Nadya back. Can you
hear me?
Yes,
I can hear you.
Yeah.
I'm moving around to find good spots.
Yeah. Okay. We had one question about like this. It was setting up simulation program is very expensive and not everyone has the funds to buy the equipment. We have limited resources. Do you have any tips on how we can use simulation-based training in our setting?
Thank you very much for that question. I think it touches upon a very important point. Buying high technology simulation equipment is really expensive. But actually, I don't really think we need to invest that much money to be able to start with simulation-based training. The most important thing for me is that we clearly define our objectives when it comes to what we're trying to teach and what we're trying to train people in. I would say the biggest challenge is having trained trainers to be able to start, for example, a program. It is quite, I mean, it is a challenge, but we can overcome many of the technical problems with material by being innovative. We don't need high technology mannequins to have a high quality simulation. So I think we can also use available equipment on site, borrow material, but above all, really have a very clear plan on what is my objective, what am I trying to do, because actually the simulation scenarios and so forth are just an excuse to be able to discuss and to debrief when it comes to teams training. When it comes to the procedures themselves, of course, the best would be to have equipment that we can reuse and they can stay, but it is a challenge, and even low technology mannequins, I would say, are well suited. However, it is a large investment. The biggest challenge in the end is to have the okay from the deciders and to have sufficiently trained trainers to be able to keep this program going. So I think the message is you can be creative, be innovative. The main thing is really the pedagogy behind it more than the equipment. You can go a long, long way with very little, in my experience. Thanks.
Thank you so much.
We have another question in the chat.
Yeah, I think Professor Schmölzer replied to that one. The question,
The one on when to stop?
yes.
Can I ask a question to Professor
Yeah,
Schmölzer?
of course.
Because I learned so much. Thank you for the brilliant presentation. I have actually a few questions, but one of them is related to the 3-to-1 ratio. So I learned now that we're looking into sustained inflation. So I'm really excited to see where that takes us. But in the meantime, when would you switch on to more like a pediatric rate? I know there's been a lot of debate, and some say that it's only the 3-to-1 is only for the transitional period, which makes sense. On the other hand, centers like mine, we decided we're so bad at CPR, so we need to train everybody in just one thing to be sure at least that we're doing that correctly. What is your opinion?
Well, I think, again, like if I look at our side, we would do 3-to-1. And if it's a cardiac kit, for example, we would always do pulse, like 15-2, and then continues with asynchronized chest compression. So that's for any cardiac kit, that's our approach. We also, when the baby switches to 44 weeks, we would switch to the pediatric, because the first 4 weeks or 28 days is the neonatal period. So this is what we do in our hospital. That's our approach. I think there is no right or wrong answer to when to switch. I'm not sure if PALS at birth in any 23-week or term baby who just has asphyxia is the right thing to do, because none of the animal studies showed it improves outcome. So I would stay with 3-to-1. I wouldn't advocate for CCSI, because there's 2 studies, 2 small studies. It shouldn't be taken and run with it, because there needs more trials before this can be done. It wouldn't go into any guideline with this amount of data either. I hope not. So I would stick with 3-to-1 for now. It might be unsatisfactory, but given that this is what the guidelines say, it's really hard to move away as long as we don't have any evidence to suggest there's anything better about it.
And you do so until corrected term then in your unit. Yeah.
Yep.
Which would do also. Yeah. Okay. Thank you for that.
No worries.
Lovely. Okay, let's see if we have some more questions. Let's see. Something for Dr. Yousef. Thank you for your presentation. You talked about cross-training and shared mental methods. I'm educator of advanced clinical neonatal nurses. What, to your opinion, is the most important technical and non-technical skills they should be mastering?
Well, thank you for that question. And I really need to think. That's challenging. I really think that I'm not pretty sure there is a most important technical skill when it comes to how I see cross-training, because the end aim is that we share the same mental model. When we trained the nurses in my setting, usually don't intubate, intubation, their first response, of course, they managed to do that beautifully. But the first response was, oh, now I understand why it takes so much time. Now I understand why. I mean, we're sitting here saying, go on, go on. Now I understand why you're doing this and that, especially when it came to nasotracheal intubation. And then we, as physicians, learned to set up lines and stuff. And then we said, oh, now we understand why it's so complicated. So this actually gave us the possibility, when faced in a stressful situation, that the nurses who then will help the physician intubate were able to anticipate the needs and would have been able to intubate, but that was not the point. And the same goes if the nurses are occupied doing something else, if somebody can, I mean, we know what the steps are. So faced with a stressful situation, things flow much easier. And then there's kind of trust that builds up. We know one another, we have one another's back. So I say the non-technical part would be most important. When we go together as a team to a situation, the fact that we actually have the same references is a huge help, in my opinion. And it also builds connections. The other thing is that we have many nurses and the teams will change all the time. But if everybody, which is a bit utopic, but if many people actually trained in the other's point of view, it's much easier to work together when we have to go quickly. So I do hope I answered your question. And we're very excited to learn how you do that in your setting.
Thank you, Nadya. Thank you both, Professor Schmölzer and Dr. Yousef, for your time. Thank you to the audience for staying with us and for the questions in the chat. We will send out the recording, or there will be an email with a link to the recording within 48 hours. So you can look at it afterwards as well. And for those of you going to Jens' meeting in Rome, we hope to see you in Monivent booth number 2. And yeah, Maria, would you like to add something?
I think that's it. Thank you so much for great presentations. Very interesting, both of you.
Indeed. So with this, we bid farewell then. And yeah, hope to see you guys.
Bye-bye.
Okay. All the best. Take care.
All the
Bye-bye.
best. Bye-bye.
Thank you.
Bye-bye.
Bye.